we set ourselves numerous challenges with quite high metric targets on them. For example, reducing face-to-face outpatient follow-ups after surgery for benign gynaecological procedures by 90% was a huge target for us, and also piloting proof of concept of some community clinics to try and better serve our patient population, avoid them having to go to secondary care appointments for things that could be managed more locally.
So basically what we've done is created an electronic referral form which the GPs use, which will allow this triage team to triage the patients into the most appropriate clinic in secondary care or community or primary care. The patient will probably get a shortened journey and will see the right clinician at the right time and be therefore treated effectively and discharged pretty quickly. So we hope to reduce the waiting times, and we hope to get the clinical outcomes to improve.
For patients, we've managed to divert some activity out of secondary care into community care or into primary care. So for those patients, that means it's a shorter waiting time, care is closer to home, they can have their treatments and be discharged, so there's a less of a need for a follow-up. So it's an improved patient experience all round. So I think the 100-day programme has given us the impetus to work across the whole system. So we've worked with the primary care clinicians, with community colleagues from Lincolnshire Community Health Services, with secondary care from our main acute. We've also involved public health, who are part of Lincolnshire County Council. So we've all worked together as a system on this project.
We have provided clear guidelines for general practitioners, and that's meant that we can use the patient's time and resources more effectively.
In terms of actual tangible benefits, we've actually got pathways out for GPs as an educational tool. We've actually started already developing pathways for other specialities, for other conditions as well, to try and support consistency for patient care. Benefits certainly in terms of delivering community clinics. I think the more we can offer portfolio and interesting careers for GPs, the more we're likely to keep that population working within the NHS. I think the traditional model of 10 sessions, 5 days of just undifferentiated general practice isn't as attractive to younger GPs, so allowing GPs to deliver more varied clinics within their working week, I think is going to be of huge benefit to the system. I think from secondary care, in terms of benefits, by reducing face-to-face follow-ups, we can free up some potential clinic time, so patients hopefully who need a first clinic appointment will be seen more quickly rather than a longer referral wait.
So we've got some standard referral forms with guidance, we've got some new clinical pathways, we've got websites that we can signpost both patients and professionals to, so there's some real clear tangible benefits, and then there are the other benefits around patient experience.
We want to continue this and take it beyond the pilot practices that we have used it in and spread it across the whole CCG. So that's the first step, and the other is that we are going to get some feedback from the pilot practices and the general body of GPs in the CCG to see whether they would be happy and what the pilot practices have felt this has done for them, and whether the other GPs would like to take that on or not. But we'll have to do that in a protected learning environment, and we're going to have a GP educational session which is already scheduled for October, during which time we will get all this feedback from the GPs to take it forward.
Yeah, so I think there's two important pieces of work. One is the GP education, and then the second thing is really sharing what we've done with other people, with other organisations.
The challenge that Chelsea and Westminster Hospital set and the wider CCG throughout North West London was to change the referral system for the GPs when referring gynaecology patients to secondary care.
The benefits that have come out of the 100-day challenge really are implementing change for patients, starting on a journey which we're certainly going to continue. One of the biggest things, certainly for me, that's come out of this entire programme is that rapid cycle change and just getting on with something and giving it a go. And that momentum of change is something that I think is key, and we want to carry on looking at everything we do within our area with that methodology. The 2 pilot community gynaecology clinics that we did The patient feedback was fantastic from those clinics, but again, that was at small numbers really, so we'd like to see how that translates when we do that on a bigger scale. I think initially within the 100 days, the reduction in follow-ups, face-to-face follow-ups after benign gynecological surgery probably has had the biggest impact in terms of metrics quickly, in that we reduced that by up to 30% from what it was previously. But again, that's a starting point. We want to expand on that.
Our next steps are to involve all clinicians in the new referral process that we've implemented and to ensure that all the new guidelines are used. Actually, having a time pressure is actually incredibly useful when you're trying to set a challenge like this. It can seem very overwhelming, but it means that all members of the team use the time effectively and we all communicate to the best of our abilities.